Okay. Good morning, everyone. Thank you for the organizing committee for the opportunity to present today. So my topic is MIS in Exenteration, how we do it safely. I don't think that can do it safely. So it's very difficult. So I have no disclosures. So this is my outline. I'm going to start with the core concept of how to perform the safe MIS Exenterations. And I'm going to tell you about my journey of MIS Exenteration, long and short, okay? And individualized Exenteration planning and stepwise approach for the various kind of MIS Exenterations. So as we know that the T4 is very strong factors driving the oncologic outcome. Even T4 and 0, no lymph node metastasis at all. The survival is worse than the T1 to T3 plus node positive. This is what we know. However, if you do R0 resection to the T4, you can get a very good outcome. So how we do that? So we need the multi-visceral resections, and then we need R0 resections for the T4 cancers. So, and then to get the better outcome, right? So I have to divide the core concept of how to perform a safe MIS Exenterations. You need to do the safe MIS first. You need to be the master of doing the safe MIS, and then you need to mastering the safe Exenteration in the same time. So you need both safe, and then you're gonna get happy, right? But actually, as Prof. Che said, we have a lot of fear, and actually, it's very difficult to do the safe Exenterations, MISly, right? So the journey of performing the MIS Exenterations is very important. You need to gain the experience one by one, and then you can do the safe one. So I'm gonna talk about my journey of the MIS Exenterations. So I joined King Chulalongkorn as a fellow in 2010. So I learned how to do very aggressive surgery from Prof. Shushit, my mentor. We cut everything, the high sacrectomy, low sacrectomy, plus T4, multi-visceral resection. We do everything. So this is what I learned from King Chulalongkorn Hospital. So we just published our the unfolding the arts of the methodologies approach for the total sacrectomy. So this knowledge of doing high sacrectomy make me more confident doing the T4 pelvic cancer. So let's skip. My mentor who teach me everything about the MIS is Professor Shea. So I went to Kyupuk University in 2013. At that time, you can see my little daughter here. At that time, it's like more than 10 years ago. And I think here's the hospital, Kyupuk University, but Professor Shea tell me this morning this is not. So I don't know who has the hospital, maybe somewhere around here, maybe. Okay. So I learned the fundamental of MIS from Professor Shea. And then especially the lateral compartment. You know, when you deal with T4 cancer in the pelvis, you have to know everything about the lateral compartment. So I learned everything, the lateral dissections, no dissection from Professor Shea. And I published my own data too. And then 2014, I started my own robotic Exenterations, my first case. And then in 2016, I have give a presentation in Brazil about our data, about our preliminary data of the Exenteration MISE. At that time, we used SI, which is not comparing to the XI, but doing pelvic surgery, just Exenteration, I think SI is good enough. Yeah, so that's the vector space. Yeah. I have lots of videos. I can skip this one. This is old version. And then I went to the MD Anderson, learned everything from my Chifu, Professor Cheng, teach me radical surgery, MIS and everything in MD Anderson. So this is the journey of how I can perform the MIS excentrations, which is long. During my training, I published the first robotic total pelvic excenteration in DCR 2017. I have an opportunity to write chapters about the robotic total pelvic excenteration with Professor Julio Aguilar from MSK in 2020. So individualized extension planning is very important. It depends on what kind of structures that you need to resect. Like this case, the red dot is the tumor. The line of resection is going to be the yellow dot, like that one, like this one. Yeah. So neoadjuvant treatment and MDT is very important, I have to say. This case, after the TNT, the tumor shrink a lot, but still need the excenteration. So I can categorize the type of excentrations to the structures that tumor invade. So if the tumor invade the anterior compartment and in females, uterus, we just need the posterior excenteration. But sometimes it invades the dry bone, bladder, and prostate. In the male patients, we need the total pelvic excentrations. So this is a case that involves the vagina and the uterus, that we need the PPE. And here we need the TPE for sure, right? This is the bladder, and then this is tumor that's invade the bladder. And sometimes if the tumor invade at the posterior compartment, especially the bones, we need to cut the bone en bloc too. And if it's going to the lateral compartment, like this one, or there's a lateral nuts, and then invade the anterior compartment to the prostate too, this case need the excentrations plus the lateral compartment dissections. So, and the last involvement is the perineal. You guys may never see this kind of big tumor in the developed country, but in my country we have a lot of this kind of case, which need the total pelvic extension plus perineal reconstructions that I'm gonna mention after this. So I'm gonna start my stepwise approach for various kind of MIS excentrations. So this first case is male, almost 60 years old, BMI 31, obstruct circumferential mass of 10 centimeters above the inner verge, motive. So we done the diverting loop colostomy, neoadjuvant chemoradiations, followed by the consolidation CLOX. So this is how we do it here in King Chulalongkorn Hospital. So same case, 58, but during I do this slide, he is 59 already. It's 1 year. So the tumor is here, invade the triglone. This is the critical margins, and so on the back side involve the presacral fascia too. So the plane decision is the green one, like this. And the lateral, the posterior, we need to unblock the presacral fascia. So I start with the medial to lateral. Now we use XI already. So I skeletonized, I retrieved all the lymph nodes around the IMA. All the lymphatic tissue around the IMA was retrieved. In this case, I do low ligation because at first I'm not sure that I can be able to do the anasmosis or not. And then at first I plan to do the colonic flap for pelvic floor reconstruction. So I keep the left colic artery as a pedicle of the colonic flap. And then this is the IMV. And then posterior dissections. I do one plane deeper from the TME usual plane. The dissection plane is wider than usual. I use my own kind of suctions. Actually, it's an NG tube because I don't want to fight with my assistant holding the suctions, so I suck myself. I mean, no. I mean, I do suction myself using the NG tube. Okay, this is lateral dissections, the wider plane than usual. So you can see the external iliac vein here. And then this is a left obturator nerve. This is the uretero-hypogastric fascia. What Professor Shea always said, this is plane A. Okay? And this is the superior vesical artery. I move the suction around by myself. And this is the vas deferens. And this is the umbilical artery remnants. So I do like from the posterior to the left and to the anterior, like that. And now we go into the retrospace. Here's the pelvic symphysis. Here's the retrospace. This is the dorsal venous complex. And then I divide the ureter later. Here, this is the left ureter. Like that. Move the ureter out. So I do the same things on the right side too. Here's the vessels, superior vesical artery on the right side, and the inferior vesical artery on the right side, So after finish, I let the urologist come in, resect the urethra. Like that. And this is the specimen look like. So this is the first scenario. This is the second scenario. The tumor invade the posterior compartment, especially the sacrum, that we need the high sacrectomy. So the problem of the high sacrectomy is lots of veins and vessels around the area that we gonna cut. If we don't control it up front, you're gonna get exsanguinations during the bone cutting. So what we do is doing the laparoscopic vascular control before do the high sacrectomy. So here, as we see, internal artery and veins, and then this is the line that I need to cut. It's around the S1 to S2. So I skeletonize and control the internal iliac vessels, especially the one that in front of the bone cutting line, the veins and everything. And as you can see, here is the nerve, the sacral S2 nerve. This is the inferior gluteal artery. It's cut. And then the resection line is gonna be somewhere around here. So all the vessels that in front the bone resection line, I control it all laparoscopically. This, and do the sacrectomy safely. This is I do it prone. Usually I do high sacrectomy usually prone. Even low sacrectomy, I do prone too. In some center, they do by lithotomy, but I think the prone is easier for me. Yeah, moving everything out. So this is a patient that the pictures. This picture is, oh, sorry. So the lateral compartment, you need the lateral knowledge. See, we need to remove all the vessels at the lateral compartment as lateral margins of the tumor when the tumor invade to the lateral. So like this, I need to control all these vessels and then bring all the vessels attached to the tumor as the lateral margins of the tumor. We call that extravascular dissections. So this is the case that I just performed maybe last 6 months, maybe, right? So this is huge tumor, left lateral side wall involvement, anterior compartment involvement. Actually, it's GIST, and after 2 years maybe of neoadjuvant, the tumor is still there, and then patient has a lot of toxicity to the agent. So this is the place that involves the lateral, that we have to go outside and do the extravascular dissection and use all the internal iliac vessels be lateral margins of the tumor. Okay, so how we perform is like this. So IMA management as usual, lateral dissection as usual. Yeah, the anterior compartment rest space as usual, and go to the lateral. So I can control all the tributary of the internal iliac vessels attached to the tumor. I do the same thing on the right side too. Like this one is the left superior vesical artery. And then superior vesical vein. And here is the left inferior vesical arteries and vein. And unblock the obturator muscles fascia, because the tumor invades the obturator muscles too, as you can see here. And then move the dissection plane outside, like that. So this is the external lateral compartment, dissections, okay? So the last one, the last scenario is the perineal involvement, large perineal involvement. After the TNT, the tumor is still there, but shrink a lot. And the MRI shows invade to the urethra, bulbous part of the urethra, the penis, and then also the perineum body, prostate, and everything. And also have the lateral nodes too. So what we do is excentrations for sure, with the lateral node dissections en bloc. So as usual. But this case, I gonna keep the left colic artery or first part of the sigmoid to make a conduit, colonic flap, because we need pelvic reconstruction, because we need like a big excentrations en bloc with a perineum, and then you can have big defect that we need to reconstruct. So go wider as usual. This is the external iliac artery and veins, the vas deferens. And you can see here's the lymph nodes. Here's the huge lymph nodes on the left side, and this is the external iliac vein. Pubic bone here, obturator muscles here, and then obturator nerve. I gonna skip. This is the internal iliac artery that I gonna control at the root and vein and everything. Okay, on the right side, do the same thing. Yeah, you get boring already, huh? Because I do the same things, the exenteration plane, right? And then I cut the penis en bloc, remove everything, do the colonic flap. I removed all the mucosa of the sigmoid conduit, and then make in like a biologic mesh to prevent the perineal hernia. This is what we see from inside. Okay. So this is a specimen look like. This is after 1 year follow-up. So our data in King Chulalongkorn Hospital, 10 years of experience. We got total pelvic exenteration by MIS, 118 patients. We exclude all the multivisceral organ resections. The survival and overall survival and recurrent-free survival is the same in selected cases. In conclusion, ladies and gentlemen, safe MIS plus safe exenterations equal to safe MIS exenterations is a kind of my daughters told me to write this down. like a equations. Yeah. And the MDT for neoadjuvant treatment strategy is crucial in locally advanced rectal cancer. Good surgical planning for achieving the R0 resections are the key of success. And minimally invasive approach for supraradical rectal cancer surgery is feasible, safe, and comparable oncologic outcomes in selected patients. Thank you.
Yes, thank you, Dr. Songphol. It's really fantastic. Thank you for your work. And then for the next speaker who will talk to us